of Complex Care Management. I'm Judith Schaefer. I'm co-director of the LEAP Learning Community. Our webinar moderators today are Dr. Margaret Flinter, who is the Senior Vice President and Clinical Director of Community Health Center Incorporated in Middletown, Connecticut, and Dr. Michael Parchman, who's Director of McCall Center for Healthcare Innovation here in Seattle, Washington. PC LEAP, Primary Care Teams Learning from Effective Ambulatory Practices, is a national program of the Robert Wood Johnson Foundation located at the McCall Center for Healthcare Innovation. Today we're going to hear from 4 LEAP sites about their innovations in complex care management. But before we do, I'd like to encourage you all to actively use the chat boxes that are located on your screen. That's going to be our main method for communication among the participants. Can you please ask questions or comments you might want to pose at the end of each presentation by using the chat box? In order to see the chat box, you might need to move your cursor all the way to the top of your screen and click on the chat icon that appears there. And then in the chat box itself, note that there is a send to line, and we request that you please click the down arrow and move the cursor until you select all participants so that everybody can see your comments and questions as you chat them in. Could you go to the next slide, please, Donna? So you'll see from the agenda that we're going to hear from 4 presenters today, with an opportunity to have questions and comments between presentations and at the end. Again, please chat your questions and comments into the chat box. With Dr. Ali, the 3rd presentation for today, that's the Southeast Texas Medical Associates. We're going to forge ahead with some technology innovations that we made here. We're using some pretty basic techniques to show you a 2-minute video today through this WebEx interface. We're really hoping that all of you can hear the sound, whether you're listening on your headsets, on your telephones, or through your computer's sound system, or VoIP. And we apologize in advance for any problems or poor audio quality on this. We're doing our best, and we hope that you'll all be able to hear the Southeast Texas Medical Associates' excellent video on their Care Transitions program. So with that, I would like to turn it over to Dr. Parchman to get us started on the content of our webinar today.
Thank you so much, Judith. It's really exciting to have all of you on the call today. Thank you for attending. Our topic today is how we care for our more complex patients and the challenges that we face in doing that. I think we all can agree that our patient population today, many of them are more complex than they used to be even 10 years ago. Look at the number with mental health, behavioral issues, frailty issues, functional limitations, and multiple chronic illnesses. It can often pose a real challenge both to the caregivers and the primary care team that's responsible for their care. Today we're here to talk about how do you innovate around supporting the care of this population, even for patients who have more simple care coordination needs. How do you do that, both within your clinics, within your larger organization, which team members do what, when, and with whom, how do we measure this, how do we prepare and train our workforce for this. So here we're going to hear from 4 of our LEAP sites around some innovations they're doing. And I'm going to turn the pass the baton over to Margaret to do introductions. So Margaret Flinter, thank you for doing our introductions of our panelists.
Well, thank you, Michael. And I think the key word that you had in there is innovation, because for all that we talked about care coordination and the NCQA and patient-centered medical homes have emphasized care coordination for complex patients, there hasn't been a great guidebook, recipe book, and so we know that you've all been very creative in how we bring this into primary care and are doing this for the topic of a webinar derives, of course, from our learning community, and this being identified as just a key area of interest and concern to people in the LEAP community. So, of course, we went out and scoured the countryside, didn't have to look too hard to find 4 tremendous groups who have in common that they have thought hard about this issue, that they've created something, implemented it, are studying and evaluating it, and have something to share with the rest of us. And I have to say that most of the people who are presenting today are just emerging from some of the coldest weather they've probably ever known in their lives. So we particularly thank you from the north, the south, the southeast, and southwest of the country for joining us. I think the range of temperatures for our presenters today is somewhere from about 8 degrees to, of course, Dr. Holly at 57 degrees down there in Texas. You actually get to balmy weather while the rest of the folks shiver. We're going to hear today from 4 groups. From Maine, from the Penobscot Community Health Center, from down in New Orleans with the Daughters of Charity, from Texas, from Southeast Texas Medical Associates, and from West Virginia, the folks from Cabin Creek. Our presenters are going to be Kathy Bragdon, who's speaking from Penobscot in Maine, Russ Arno and Grace Mena from the Daughters of Charity Services in New Orleans, Dr. Jay Holly at Southeast Texas Medical Associates, and then from our friends in West Virginia at Cabin Creek, Craig Robinson and Amber Christ. And just to repeat how we're going to do this, we're going to go in that order. We're going to start introducing Kathy Bragdon. At the end of each of the presentations, we'll have time for some questions, as well as at the end of the full program. I'm just giving the name of the individual and the organization, but I am going to ask each presenter as they start to just give us your role in the organization and maybe your role vis-a-vis care coordination in your practice. So, Kathy Bragdon, let me turn it over to you to start us off.
Thank you, Margaret. My name is Kathy Bragdon. I'm the Director of Care Management at Penobscot Community Health Care. And we go right to the first slide. Next, there we go. And I thought it was important to tell a little bit about the model of the care management department at PCHC. Significantly since 2010, with 4 RNs and 1 MA health coach. As of right now, we're a team of 28 staff, includes RNs, medical assistants, licensed workers, and some administrative assistants. We also have great access to pharmacy data, which has been really, really instrumental in our growth. The focus on for our care management is our embedded care management, transition care management, and our community care team as far as if we're dealing with the most complex patients. Next, please. One of the first additions we made to our care management team was the transitions care manager. This position is kind of unique because it's a practice-based registered nurse. She comes at the facilities. She's like a liaison, really funneling some pretty important information from the local hospitals, the facilities, back to the patient's medical home. When we can, we try very, very hard to meet with the patient in the hospital, trying to figure out what barriers and what challenges they may face at the time of going home. This has been empowered to make referrals to our embedded care management, social or community care team, which we'll talk about in just a second. The big roles that we didn't realize how big it was going to be was there was a tremendous amount of patients who had primary care at time of admission, and we really closely with the hospitals to provide that services and make that linkage to those who need a PCP. Next slide, please. Our first and probably the largest pieces are embedded care management. And these are at our larger sites. The teams consist of RNs, our MA health coaches, and social workers. And really goal is to include improve self-management skills, decrease hospitalizations, readmissions, and improve quality. We have face-to-face visits and phone calls for education, coaching. And then we started having an increased focus on the hospital follow-up. We try very, very hard to reach every patient. 40 to 72 hours post-discharge from acute care, cycle coming along, and if you were walk-in. And in trying to do that, we were trying very, very hard to make sure we're using the right tool for the right job. Patients are coming out sicker. We want to make sure that we use correct staff to make that call. So a while ago, we started trialing the modified LACE tool to determine risk for admission. I'm going to do this very quickly. Basically, we use a scoring system that looks at length of stay, conditions, comorbidities, and emergency room use. And on that score, we then assign either high, moderate, or low risk for readmission, and determines who makes the follow-up call, what practice-based service can we offer them, whether it's care management or a community care team, and how they have to be seen in the clinic by the PCP. Risk calls are made by our MA health coaches. We're to get a med reconciliation at the time of the phone call, and we offer a space call about a week after their follow-up appointment just to make sure that they still have no questions. We found that has been really successful, and it's also been very, very helpful having the transitions ease up if there may be issues when we make that hospital follow-up call. For instance, if a patient really should have home health but has been resistant at time of discharge, we can, because we know to kind of focus on that. Next, please. The last branch that really works with our most complex patients is our care team, and I lovingly refer to this program as care management on steroids. It's designed to be brief for period of intervention, very, very intense, offer the same level of support, well, the same support, embedded care management, meaning we offer face-to-face visits, and we also offer the additional piece of a team visit with an RN and a social worker going to the patient's home. It could be a homeless shelter. We meet them at Dunkin' Donuts. Sometimes we meet them in their primary care office. We do this because the RN and the social worker look at the situation through very different eyes. They're looking at different things, and it's been very, very effective in trying to figure out what's driving that person to the emergency room. This was grant funded through 2014. It's actually a pilot project. Our Medicaid program, Maine Care, Mayor, Anthem, Harvard, Pilgrim are all participating in this initiative. And it's really focused on the highest utilizers of healthcare dollars. And in the lower right-hand corner, there's a graph that we presented that talks the effect that CCT has had on these high-cost patients. And this was based on 55 Medicare patients that were during that third quarter. Used that national average of a $1,300 fee. So the 6 months before CCT intervention, the cost of Maine Care was $395,200, and then 6 months after, it was down to $192,400. So it was pretty significant savings for the state. And we've had successes with the other payers as well, but this one is what we have most data on. Next slide, please. Important thing that has been helpful for us is how supportive leadership has been in care management. They recognize the importance of role protection, and it's a struggle making sure that we stay true to what we're supposed to be doing and don't get pulled into a lot of things that come up urgently that end up pulling us away from our primary focus. So they've supported effort towards role protection. I think the validation that our senior leadership has shown to care management has been very important. We have care management, I sit at the senior leadership meetings, based issues. We are actually included in the new employee orientation program, so it feels like we're an important piece of the whole practice and function. We also have an agenda on every site's provider meeting, talking about patients and kind of in the limelight, making sure that providers don't forget we're here to support them. So if there's any questions, I'd be happy to entertain them.
It's Margaret speaking, and can the attendees hear me if I speak for just a moment before we introduce our next speaker?
Yes.
Perfect.
Everyone
Great.
should be able to hear you. Mm-hmm.
Wonderful. And Michael, please chime in if you have any questions. Well, I don't see a question in the chat box right now, and Judith, I'm sure you'll tell me if I'm looking in the wrong place.
I will.
I've got a couple of follow-up questions. Go ahead.
Great. I think, first of all, Kathy, thank you. And as you know, I think you and feel about all of our presenters, I think you've created a remarkable system up there. Some of this is really trying to get under the covers and understand a little bit of granularity. How are you doing this? You're a large community health center. I know you have a number of sites in a number of cities, and you pop a figure there, I think, of 28 people in this care management division. Have you been able to develop any kind of metric or guidance that would say to a group in LEAP that's thinking about implementing a model, need for a patient population of 5,000, 10,000, 20,000, any kind of metrics on that? And my second question would be, that graph is very compelling that you showed, and I wonder if you have any other outcomes that you have in that kind of clarity right now in terms of either changes in something like admission or clinical outcomes. So maybe just a minute on that, and then I'll turn it over to Michael for his follow-up question.
Sure. The part as far as building a program, there's various different and like sizes and that are out there. I think for commercial RN, what they call for the commercial population, I think an RN for one for every 5,000 patients. So, we have learned, and luckily we went about it well, is that we've grown slowly. It seems rapid for 3 years, but that we didn't overhire at the very beginning, and this was all grant funded at the very beginning. And during that grant funding is when we tried to figure out, how are we going to be sustainable? And that able to grow the program is increasing engagements with third-party payers, contracts to provide care management, showing data, main care graph that I put up there. There's no hard and fast rule out there as far as panel size, but what we found is, I laugh and say we use the cry uncle rule. You're so busy that your referrals are 3 weeks out and you're ready to cry uncle. That's when you add more staff.
Thank you.
Sure. Could I just ask just a brief background question, getting under the hood a little bit further on this? What kind of training or background do people in your community care transitions team have?
We have bachelor's level registered nurses, and we have licensed social workers. And what we find is that medical problem driving them to the hospital, but it's the psychosocial barriers that are repeating the cycle. They have been instrumental in figuring that piece out. And we all have motivational interviewing training, and we try to, as new staff members, we try to add people who have expertise in some areas. We have a educator, we have someone who's really, really up to date on COPD and asthma. So you build the team. I mean, that's how I describe how we try to build it here.
Right. Right.
So I see a couple of questions in the chat room. Did you want to read those, or would you like Michael and I to take this?
Go ahead, and if they're available to you. Mm-hmm. I
can see them, and before we move on to our next group, let me just put these out to you, Kathy. The first are the people on the care coordinator team, all social workers, is a question, and the second is interest in the model of physicians providing hospital care, whether your physician leaders are employed by your health center, patient center, medical home, or the hospital, and how do they interact with the care management team? And I'm going to ask you, that's a chunky question, I'll ask you to answer it briefly. Thanks.
Okay. Our CCT, our community care team, has social workers and registered nurses. There's a hospitalist practice that does all the inpatient care. None of our physicians go in except for the pediatricians who go in for the new babies. Our physicians, nurses work most closely with the plan of discharge at the local hospitals, whether they are in care managers or social workers. And we do facilitate physician-to-physician contact. Of our work is with the people planning the discharge.
And I see a third question came in, Michael, but I'm thinking it might be one that people have for everyone. everyone. And do the care managers get involved in adjusting medication? So maybe we'll wait that one for all the presentations and take it as a group question. Does that make sense to you?
Sounds good. Why don't we do that?
Perfect. Okay. Kathy, thank you so much. And let me
Thank you.
introduce Roz Arno and Grace Mena from Daughters of Charity Services in New Orleans.
My name is Grace. I work at Daughters of Charity here in New Orleans. I am a registered nurse, and I'm working as a care manager in our Metairie facility.
And I'm Rosalind Arnold, Chief Nursing Officer at Daughters of Charity. I oversee the quality at all 4 locations, and that we have standards of practice at soon to be a 5th location. Just start, Margaret?
Absolutely. Go ahead.
Okay, you can go to the next slide. And that's just a picture of one of our facilities. That's our Captain location. We just opened one in New Orleans East, a portion in New Orleans East, 6 this Monday, and it's just a little bit bigger than this one. So it seems like the more we grow, the bigger the facilities get. So let's go over who are some of the members of our team, our care team. We refer to our team as the integrated care team. Members are the registered nurse, the patient care coordinator, and the social worker. However, we do have some other members of the team, and we collaborate with one of the local universities, Xavier University, to provide clinical pharmacists as well as certified asthma educators. What I'll do now is go into just a brief description of each role. The care manager is responsible for identifying patients that are not being monitored or treated appropriately by the provider. Focus on patients with the highest risk. These are usually patients who have complex conditions and may have hospitalized. They have comorbidities. They had a good portion of their time on care transitions. About a year ago, we implemented the GNO-HIE. We became a part of that movement where patients who are admitted to our local safety net hospital, and then we do have some other hospitals that sign on, but the main one was our considered charity hospital. The HIE, the Health Information Exchange, was implemented there a year ago, and our care managers receive notifications of patients who have ED visits as hospitalization. So the nurses do respond to those notifications. We'll talk about that a little bit when she talks about the role of their manager and what we're testing at one of our other sites. But that is where the nurse spends a good portion of their time as well, making sure that patients do receive a follow-up appointment. When they're discharged, they have medication, and they understood what took place during the time of their hospitalization. Medication reconciliation at that time. The nurse engaged the patients through motivational interviewing and coaching. They provide that intense follow-up for patients with chronic conditions. Next. Patient care coordinator, administrative support. What that means is that they are maintenance for patients, for services that we do not provide on site. Them happen out in the community. So they are making sure that the patient gets the appointment and that the patient is aware of when that appointment takes place. A lot of the systems that we refer to, we don't know when that patient will receive that appointment. So care coordinator follows up, find out when that patient appointment is, and communicates that to the patient. A lot of times the system have already notified the patient of when that appointment takes place. They also work with the care manager to make sure that preventive medicine is completed. That could be mammograms, colonoscopies, PAP care, assist with the abnormal cancer tracking of those I just referred to. And then we send reminder letters. They send the reminder letters to patients who are overdue and not at goal. Next. The worker works with patients to identify what changes need to be made. They also help them identify what stage of change they're in and make small positive changes. We do that they work in the role of a consultant versus a therapist. We ask that they have brief sessions with the patients. Our goal is to extend the reach far and as wide as we can. So work with patients on helping them identify their need for change and recognizing that even though a goal is prevented or is slowed down, that is legitimate for that patient. Next. Okay, talk about the model as we're testing it now at one of our locations.
Okay, this is Grace again. I'm a nurse care manager at our Metairie clinic, and kind of like what was mentioned before, there's no perfect number as to how many patients a nurse can follow effectively until we start screaming uncle, and I think we were pretty much screaming uncle because we've had quite a bit of growth here. So we have, we're testing out a new team. Or I guess you could say we're all one team in each facility, but at the same time we're dividing up into 3 smaller teams. Each team is one physician, a nurse practitioner, a medical assistant, a care coordinator, and a medical assistant, of course, for each of the providers. We've expanded the role. And, of course, the nurse, the care manager, and the behavioral health person, a social worker or counselor, would be available for all. And in the Metairie case in particular, we have 3 teams, so we will be available for all of those. And we are still following those more intense management needs. So it just frees up a little bit more of our time for those needier patients, just need more of our attention, and we can dedicate more time to them. So in this instance, we've added the nurse practitioner not only see her panel of patients, she in a sense shares her panel with her physician, and at the same time has slots that she can use as educational visits that are extended to, I think, half hour for care management where she can talk to diabetics one-on-one. And there's a medical management slot as well for the for the nurse practitioners where they can assist in just to monitor simple medication adjustments for blood pressures and follow the in patients as well, which is something that.
Grace, I just need to tell you that we have about 2 more minutes for your session.
Okay, I can go quick fast. And okay, so basically we are readjusting our roles. We've added the additional care coordinator to kind of help with the simple health coaching, and we're trying to get them a little more comfortable in that. And as well, it's just freeing up the care manager time to address more of the HIE that Roz was talking about, the health information exchange, where we can try to pull in those patients that may be ending up in the emergency room and having them come in to the clinic to get checked up and do the med reconciliation and see how we can help keep them out of the hospital. Okay. Oh, and I forgot to say switch to the next. But is my time up? Or may you keep going? We did that. Yeah.
Go ahead, Grace. Finish this slide. Thanks.
Okay. where am I? Okay, so the only changes that we're doing is, like I was saying before, giving me more time to do the HIE, more involvement with quality, and more of a resource person for the expanded roles for the patient care coordinators, in addition to the medical assistants. Now we're trying to educate them a little bit more, and we're specifically assigned to a provider. The patient care coordinator, again, is the leader for the medical assistants. She's now, before they weren't doing medication refills, so she's been assigned to do that as well. She's getting some phone calls, and she's assisting in tracking referrals, making sure all testing that was done, that we get those results and back in the MR in a timely manner. Next.
And just be real brief with this, as you can imagine, this is a costly model. So us using a nurse practitioner in that role allows the encounters to be billable. We also added group health visits, and practitioners is dating those groups. We're looking at some other grants, HRSA grants as well, and partnering with peers who recognize the value in this. Identifying the caseload that was mentioned earlier, that is looking at what is manageable for the nurses. And then during this transitional time, we realize we need to be very clear in everybody's role, and also it'd be a little difficult for the nurses to let some things go. Next, please. Okay, so Grace is going to close out with this slide.
Just a little quick story about one of the patients, one of the needier patients that he came in, was totally confused about his medications, didn't want to use a pill box, had to go through this long, back and forth with him. He finally agreed using a grid. I gave him a medicine where he can use checkoffs, and we did various ways, and he explained his medication. So now he just was so happy once he was, feeling much better. He had multiple chronic diseases, so he brought me out to the parking lot and wanted me to show him his Purple People Eater, which is his truck that he loves, and he's driving successfully again, and he's just feeling wonderful. And he's just, very grateful to us as his leader, and as you can see, his license plate says Bikini.
Great. Grace, this is Michael Parchman. This is really, really innovative here. Can you tell me, how does the nurse practitioner and the RN care manager kind of coordinate their roles and tasks on a daily basis? Do they talk to each other? How does that work?
The key part to this is communication, because, we have our registers, and we're looking at the more critically ill patients, those that have more need. So this is done both the register and communicating individually. As the providers are seeing patients, they may bring them to me. They can flag me through the system. But it's communication.
So you guys are co-located within easy walking distance to talk to each other if a problem comes up.
Absolutely.
Yeah. Okay. Thanks.
Thank you so much, Roz and Grace, and I think we want to move on. I don't see a new question in the chat box, and we're going to hold a few things to the end, but let me introduce Dr. James Hawley from the Southeast Texas Medical Associates, and James, take it away.
Why don't we play the video?
Larry, I think it might just take a minute.
Okay.
Has discharged over 15,000 patients from the hospital. The hospital care summary and post-hospital plan of care and treatment plan has been received by 99% of patients upon leaving the hospital. The document includes a reconciled medication list, an assessment of the risk of readmission, follow-up care instructions, including appointments within 2 to 5 days.
CCPI Care Transition Quality Metrics publicly reports at CETMA.com by provider name on these metrics.
Day long discharge, the patient receives a 12 to 30-minute care coaching call. The call continues the transition process, which began upon admission and which is not complete until the patient is seen in the clinic by the primary care provider.
Patients designated as high risk for admission are entered into a 10-step program. If the patient has economic barriers to care, CETMA's foundation will pay for their care. In the past 4 years, CETMA partners have given $2 million to the foundation.
Using a business analytics tool, CETMA contrasts patients who were readmitted against patients who were not readmitted. We contrast ethnicity, socioeconomic, class, age, gender, morbidities, and comorbidities. Tools provide leverage for improving preventable readmission. Those are follow-up care coaching calls and being seen in the clinic within 2 to 5 days after discharge.
CETMA's Care Transition Program is a success, dealing with issues which commonly result in readmissions. As a result, by a CMS study, CETMA's treatment of fee-for-service Medicare patients costs 37.4% less than other practices of equal size and complexity.
Through CETMA's patient-centered medical home, I receive state-of-the-art, 21st century, compassionate, and patient-centered care.
You can see the next slide, please. It really describes in some detail the our care transition process, which begins at admission. Admission, the patient receives a care plan that's created at the time the history and physical is done. Let's see. We may need to go back a slide. I think one more slide back. Well, okay, maybe that slide got eliminated. But our care transition process is 5 steps. First, at admission, the patient gets a care plan of care and treatment plan for the hospital, making the transition from the ambulatory setting to the inpatient setting. Then the patient gets a document at the end of the hospital, which you'd be called a discharge summary. We call it the hospital care summary and the post-hospital plan of care and treatment plan. It has a reconciled medication list as well as all follow-up appointments and the details of the hospitalization, why they were hospitalized, and what their risk of readmission is. We also complete the physician consortium performance improvement 18-point data set at the time the patient leaves the hospital, and as the video says, that it says 4 years. In the last 5 years, we've discharged almost 20,000 patients, and 98.7% of the time they receive this document. Then care transition call or the care coaching call the day after they leave the hospital, and finally the care transition process is complete at the patient back in the clinic, completing the 5-step. They receive a medication reconciliation upon admission, upon discharge, upon their care coaching call, and a 4th one at the time of their being seen. CETMA has a hospital care team. It's made up of 15 people in the hospital, 24 hours a day, 7 days a week, around the clock, and that's supported by the clinic. One of the things that we do in the hospital is we're very concerned about the hospital consumer assessment of healthcare providers and systems, the HCAHPS program assesses the patient centeredness and the questions that are asked. Did your physician explain your care plan? Did your physician answer all of your questions? Did your physician listen to your questions without interrupting you? Did anyone ask if you have adequate help at home? Did your physician give you in writing the symptoms which would make you need to return to the hospital? We are doing our own HCAHPS audit, and we posted that on our website for us through December, and of course the hospital has a paid vendor, and we do that with the hospital. May I see the next slide? Follow-up visit is really critical because it's the final step of the care transition process, and that process is not complete until that visit takes place. A number of things happen at that visit. We have the potential for referring people to the care coordination department for more than simply the care coaching call, particularly if they have barriers to care, which represent they can't afford their medication, they can't afford transportation. We've had a number of patients that need dental care, and we've seen absolute stopping readmissions simply by making sure they get the dental care they need. They can be done with a click of 3 buttons, and it goes to our care coordination department, which has access to the finances of the Setma Foundation. Next slide. This copy of that care transition, you see down the coordination, down at the left side, you see the various things that normally are done. You click a button there, and then you click the red area, click to check to send to care coordination. With 2 clicks, less than a second, the provider has transferred that responsibility to the care coordination department rather than having to spend time leaving the room to try to coordinate something that can be done very easily. If a patient needs dental care, diabetes, self-managed education, living expenses, medication, medical nutrition therapy, procedure, transportation, whatever their needs are, they can click that button, and the care coordination department will contact them, and if we're able to, we will give them assistance to accomplish those things. We found that this system has integrated a number of complex problems that have befuddled physicians for years, and now we can easily provide those in the context of the continuity of care and the transitions of care, which are critical parts of medical home. I think I can conclude there, and on my presentation, that's the last slide, I believe. And if there are questions now or later.
That's great. Thank you so much. Can you tell us, describe for us the care coordination department? Who is?
Sure.
Who are those people? What's their background and training? How many of them are there?
We have 4 people in our care coordination department presently. 2 are RNs, one's LVN, and one of them has no formal medical education, but administered a psychiatric practice for over 20 years. And when her practice went away, I heard that she was available and realized who's more about care coordination and complex care than a person that's dealt with a psychiatry practice for the last 20 years. She's done a fabulous job and adds a great deal of expertise, particularly compassion and caring of patients. You can't find a more patient-centric person. And so it's the people that do that work. A lady who was just one step away from the job because she couldn't concentrate. All she wanted to do is talk to people all day, and we found a place so she can talk to people all day, which is her job.
That's great. Okay, one more question, and that is, does the care coordination people department also with referrals from your outpatient clinic setting?
No, a separate referral department. They only get involved if there's need for support, financial support to pay pays or other things. Our foundation doesn't pay anything to Setma. It all goes to other. That's the only time they get involved.
Yeah, that was the nature of my question. Is if I'm an outpatient provider and I have a patient with a transition need, I can refer the patient to the Department of Care Coordination.
Absolutely, and they'll get that taken care of.
For more complex patients. Okay.
Right. Yeah, it's amazing how the care is decreased simply because the patient can't get to the site of care. It can't always take the site of care to the patient, and simply a gas card can often solve that problem.
Great. Thank you.
Thank you.
Margaret, are there other questions?
I don't think right now. I think we probably want to move on, but I do want to say for all of the people who've presented so far, and nothing less than we would expect, let the understanding that this is about so much more than medical care, that it's about the social reasons of people's lives, the financial issues, and of course, as a community health center person, I so appreciate your reference to get to the root of the problem, and if dental issues are the root of the problem, get those issues. Don't just keep churning people through because we haven't been able to address the fundamentals. So thank you so much for that. And with that, I do want to turn it on to our fourth group that's presenting today from Cabin Creek in West Virginia, Craig Robinson and Amber Christ. So Craig and Amber, you're up.
Okay, I will introduce myself. I'm the Executive Director of Cabin Creek Health Systems, which is an FQHC with sites in one county, 4 rural sites in southern West Virginia. But I'm going to start the presentation with Amber Christ, who is the Director of Education and Program Development. So, Amber, do you want to start?
Sure, Greg. Next slide, please. A little bit about a history with our work with complex patients, and Craig is going to tell you a little bit more about the meat of our work. Our work with complex patients has evolved over time and started 5 years ago when we began a project to identify our frail elder patient population. At the time, we convened an interdisciplinary medical team together to develop a definition for frail elder and also develop an intervention for the patient who met that definition for frailty. Lessons learned from this initial project over the years has allowed us to expand certain aspects of our frail elder program to our entire patient population who we have identified as complex. Thus, complex patients are often those patients that the medical providers are struggling with and who have been in the hospital and ER, often have multiple chronic conditions that are often very poorly controlled, take numerous medications. I think our frail elder, the highest number ended up being like 35, have behavioral health issues that are poor and have minimal family support and a weak social network. Next slide, please. It's important to focus on complex patients for a number of reasons. Oh, wait, my phone was sorry. It's important to focus on complex patients for a number of reasons, and one being that that's where the money is. If we keep these patients out of the hospital, we actually save the system money. That's where the suffering is, and that's also what is sometimes burning our staff out. Our providers feel alone in the room. They feel that they don't have anyone else to turn to, and they're alone dealing with all of these patients and all these complex conditions. Also, there's plenty of evidence that shows that these enhanced services work. It's work done with coaches, and it's also work done with expanded teams, and it's also our own experience of 5 years that has shown what we can do with these complex patients. Slide. I think we quickly realized that we needed to increase the complexity of our system to these complex patients. We were complex enough. I realized that we needed to expand our clinical team, that some of individuals caring for these patients couldn't just be the medical provider. It needed to include the medical assistants, the behavioral health consultants, the pharmacist, the health coach, and the administrator. And not only was it expanding this and adding these additional members, it was also allowing them to have conversations about these patients, which I think is a key part of the work that we have done, and that is actually what Craig is going to tell you a little more about.
I'd like to reiterate that this issue about the issue of conversation is that the program that we began to address frail elders in our patient population came about because it was a need on the part of the medical staff, and the program was developed and designed by an interdisciplinary group of physicians, medical assistants, and staff from all of our sites that regularly and came up with a plan. Amber mentioned this, that we're complex patients. That's where the money is. It's where the money is in terms of both where so the hospital most medical care costs are focused, but it's also where there's money in terms of grant funding to get things started, and we relied on that in the development of that frail elder program, which then we to include elderly patients with chronic conditions, and later patients that were dual eligibles, and Medicaid patients who were on Medicaid due to disability. I wanted to say a couple things about the teams that have developed to carry out these programs. First, a key member of the team was a health coach who was an MA or a man social work in our case. Received extra training, and we collaborated with a local community college to develop a curriculum to give them more background in care of the elderly and provide more various skills that are important for in the services they were providing. And the health coaches worked by telephone with patients. They established themselves as, I'm your told patient, your health coach. You can look to me. And so the calls went both ways. They did families and patients in their homes, and they became kind of experts in what resources in the community that could help those patients. A role that they played was kind of doing initial assessment, making sure that we had all of the information in the medical record and available to the that were important for the patient's care. And we found that correcting the electronic medical record was really an important role that they played. We're a part of the team. They did drug utilization reviews on the selected patients that had polypharmacy issues, which was many of them. The adults, who were clinical social workers or psychologists, did logical assessments on those patients that needed it, carried out short-term therapy. They coordinated with the outside specialty behavioral health care, if that's called for. And then in our system, they play a key role in facilitating meetings and what we call extended huddles. Extended huddles have become important in a couple of ways. Number one, it's now the way that we identify many complex patients, because the care providers or the medical assistants who are working day to day with patients will identify people that they would like to discuss with the broader team, and they present the cases on a weekly basis. These are hour-long meetings, take place once a week. Cases, and the team then comes up with an assessment. They kind of pool their information about the patient. Sometimes they one of the people from the front desk will have more information about what's going on with the family than the GP. They'll patient and then come up with a plan of attack for that particular issues and divide up the work among the people that are there. And I must say that the weekly huddles that take place at all the sites have become not for assessing and planning care of complex patients, but it's a time of regular ongoing continuing education for members of the team who are learning from each other and from the physicians, and the behavioral health people can describe what they're doing to the group, and it's a very rich learning experience. And also for me as an administrator, it's important to attend and see what's really what our teams are really faced with, and where the systems our system has problems.
Greg, we've got about 5 more minutes, so I'm wanting to hear all of your story, but so you could just try to figure out what were the most important points would be right now. Thanks, Craig.
Okay. So I actually was coming to the end of my day anyway. Just to so our current system, our current from dealing with complex patients is, number one, that we have these defined groups. We still have frail elders and elderly chronic diseases that we're following, and we're generating new patients as a result of these huddles every week where people are, the primary carers are presenting patients that are causing them the most difficulty. Most recently, we've been closely with who are payers in our community. Blue Cross for one, the Public Employees Insurance Organization is another, and Medicaid will be coming soon. But in those arrangements, we are going to be held accountable for quality and cost of patients who've been attributed to us. And so that's they're providing information on risk status and costs that we're now using and integrating into identifying patients that need coaching and this more intensive healthcare team approach. Looking forward to expanding those arrangements with payers as a way to support the in services into the future. And I'll stop there.
Great, Craig. This is Michael. Thank you so much. I'm really impressed with the expanded huddle concept. And just to let everyone know, we've posted a detailed description how-to on the expanded huddle concept on the LEAP website under complex care management. So if you want, this is from Craig and Amber. They shared it with us. And so if you want more details about how to do an expanded huddle step-by-step guide, there's one on the LEAP website under complex care management. And second, I've had an offline conversation with Kathy today. I'm going to try to get her modified LACE tool up on the LEAP website as well for you to use. So if you want more resources and tools, we're posting them weekly on our LEAP website, just to give everybody a heads up about that. Margaret?
Well, I want to thank everybody, and no surprise, people have continually reinforced how important the team is in primary care. Some of the pearls of what we know, but it's wonderful to have people put words to it, that focusing on complex care management is where the money is, but money not just in the financial sense, it's where the money is in terms of reducing suffering and making a big difference. It takes a range of people to do care coordination, complex care coordination and care management, from nurses to social workers to health coaches, MAs, pharmacists, and more, and that there is within this kind of a bit of a built-in career laddering within primary care that we know is really important if we're going to retain the smart, creative, talented people that we have and ensure that they can continually develop. Perhaps the last thing I would just note, and Craig and Amber, thank you so much for putting your finger on it, that I heard anyone else say, but is so important, is that this may be, in fact, a crucial strategy to reducing burnout of our primary care providers and our primary care teams as they struggle to provide incredible care to very complicated patients, to not be isolated in trying to move that mountain, but to have the help of a very skillful team in addressing their complex care coordination needs. So I want to thank all of you, certainly thank the team in Seattle at McCall for organizing the webinar, and encourage you to go to that comments for additional information and to add comments. Do you have anything to wrap us up?
A reminder, this webinar will be posted on the LEAP website.
Yes, and I want to thank all our presenters as well, and also let you know that Dr. Hawley's can be seen, Setma's video can be seen. We'll post a link to that on the LEAP Commons also, so you can see it in its entirety. Thanks, everybody.
Bye.
Thanks, everybody.